So now we're online. I would like to welcome everyone to this afternoon presentation about resilient healthcare. We'll start, we will have 4 presentations. We'll start with Mai-Britt Beldam from Saint-Gobain. We'll talk about Let Me Die in Peace. It will be very interesting to hear about that. David Brasfield from Sunnaas Rehabilitation Hospital. Blue-green infrastructure for climate resilient and biophilic hospitals. And then Windi, Muziasari from Resistomap, digitalization of antibiotic resistance monitoring in hospitals. And Amina Pereno from Politecnico di Torino, and she will talk about future scenarios of resilient health systems. And my name is Johannes. I will be the moderator here today. And I'm from Nordic Center for Sustainable Healthcare. We heard more about us in the morning, and we have a network with 115 members. It's a cross-sector network, so we connect both public and private, and also companies and hospitals, universities, and so on from all over the world nowadays. So we are very happy to see the interest in this field growing very rapidly. And this conference is the 4th in a row, and we're doing it together with Upgraded in Finland and DTU Business in Copenhagen, where we are today. And it's within projects financed by the Nordic Innovation and the Swedish Energy Agency. And a little bit short about introduction about resilient healthcare. We're very aware of the resilience nowadays with the corona pandemic, but there are also other aspects of resilience. And how can a sustainable hospital be more resilient hospital? As we have seen, a lot of single-use clothing have been very popular within healthcare. But now, with this situation as we are in today, it's a problem with logistics and to get one-time use garments. So like a laundry at a hospital or locally with the cotton garments may be a good alternative. It's also with single-use items. It can be hard to get nowadays when everyone wants to get them. And sterilization at site or reprocessing, as we heard about it in the morning as well, is a more resilient way to go. And dependent on the external energy, for example. If we can, in Sweden, we produce most of the electricity in the northern parts, but what happens in a war, for example, if the energy is cut, the lines are cut, there may be sustainable solutions with wind power and so on site that can produce most of the electricity. And just-in-time systems have also been very popular, but now we see the storages are used in this situation. And also food from everywhere. If we can support our local farmers and source our food from around where we live, it's also a more sustainable way of doing it. And with this situation we are in today, we see a trend, a paradigm shift within this field. And it's also many circular and sustainable healthcare solutions that can help us with the resilience within healthcare. And we can also use the healthcare resilience to set the standard for the rest of the society. So with that said, I would like to introduce our first speaker here today. And I would also like to tell the audience that you can ask questions in the chat, and after each presentation, we will take your questions and answer them. So with that said, Mai-Britt Beldam from Saint-Gobain, Ecophon. She will talk about Let Me Die in Peace. Welcome.
So thank you for the introduction, and thank you out there. I don't see anybody. I don't know who's online. I'm simply just speaking into my computer here. But thank you for being with us, and I will talk about how sound and acoustics affect healthcare. And why did I choose this sharp bite of a title, Shh, Let Me Die in Peace? Well, it has to do with the fact that it's my worst case scenario. What you see here on the picture is me and my dad 14 years ago. And this is a dear memory of mine because a few months after this picture was taken, he was diagnosed with lung cancer. And he got really, really sick and he passed away. And before he passed away, he was admitted to an end of life care home, and it was a really beautiful place. The only thing that was really troublesome was the sound. And that was when I realized, wow, this is the worst case scenario, being sick and sedated, and you cannot tell people to shut up. And you cannot tell people to fix the room acoustics because it's simply too late. And even though I work with room acoustics and sound, me as a relative, I couldn't do anything either. So this is my worst case scenario, to die in noise, because we can actually fix it. It's not rocket science. Come on, we can travel to the moon. We can fix acoustics as well. I work for a company called Ecophon, and we provide the world with acoustic ceilings and acoustic wall applications. And what you see here on the picture, that is how we want healthcare to look and sound. But unfortunately, even though we try our best to fix soundscapes all over the world, the reality looks like this. And it sounds like this. What you hear now, the background noise, I did it on purpose. There are just sounds that I actually recorded, both being a relative, but also in hospitals where I've been part of research projects. What you see here on your left-hand side is actually my mom, Victoria. She goes through a heart operation. She's perfectly fine today. And she actually has a hearing impairment. And she is really scared because she's afraid that something will happen. So when she's in this situation, she needs to follow the nurse's good advice, but she's so alert and she's so afraid that she simply cannot cope with all the sound at the same time as she has to follow the conversation. So she understands nothing of what the nurse is saying. On your right-hand side, that's actually my son some years ago when he went through an operation. And this is not during nighttime, this is during daytime. And as you can see, the environment is not really like the picture I showed you in the beginning, but this is the reality. We have environments out there that needs a redesign, and when we redesign, we should think with our hearing. And this is me. Now we have the whole family. This is me 19 years ago after having my son. And I can assure you that I'm not sick at this picture, but I was affected by noise as well. Because when you're a relative, you're also super alert. You want to take good care of here, this is my son. But if you're disturbed constantly by sounds and noise, you will be stressed out. And now the sounds stopped. I don't know how you feel about listening to me trying to have a conversation with you with all that background noise. Me personally, I find it disturbing, and I'm not sick, not at least that I know of. So the big question, how are patients affected by sound and noise? Well, this situation, what you see here on the picture, I suppose this guy, he came into the hospital with an ambulance, and the first thing he hears when the ambulance comes is a big boom, bam from the door. And then maybe the ambulance has blue blinks and it's noisy all the way to the hospital. And when you come to a hospital, you are already out of your comfort zone. You're sick, so your system will be alert because you want to survive. And actually your caveman inside or cavewoman, makes you ready to fight the situation. And we need to remember that our hearing is not designed for the indoor environment. Our hearing actually hasn't developed since we lived here, outside. And if we look at the picture here, if we look with our hearing, the sound can just travel away. The sound, if you speak with people, will pass your ears once and then it's gone. But when we come inside, we have a lot of surfaces that will reflect the sound and build up the sound. And in a hospital, you have to add technical equipment, you have to add a lot of conversations, you have to add that you cannot control anything. So we are quite challenged when we are patients and when we get sick. What about staff then? A lot of the research that we have done on staff also investigates how a work situation looks like when you're working in a hospital. Because yes, you're just having another day at the office when you're a doctor or a nurse. You're not out of your comfort zone like a patient. It's just another day. One of the things we have been looking into is the workload and prospective memory of nurses. When you are a nurse, you have some tasks to solve, but while you're doing it, while you're solving your tasks, you will constantly get new ones. So at this picture, we have two nurses in a neonatal department. They're working, they're solving some tasks, and maybe a colleague will come in and say, please remember to look at patient 5 after you have been here, and then remember the medication for patient number 7 or something like that. And that makes a nurse have load on prospective memory when you have to recall what the task was afterwards. So a question to you guys is, when a nurse starts his or her shift in the morning or the afternoon, how many tasks will there be from the beginning? I'm just giving you 10 seconds to think of a number. How many tasks will he or she has? I think that's 10 seconds. Well, what you see here, the numbers here all represent a nurse. And as you can see on the x-axis is the prospective memory load and the number of tasks. And as you can see in this example, it's 7:10 in the morning, and the nurses will start their shifts. And as you can see already before they start to work, they have a lot of tasks to solve. This is where a colleague will hand over the tasks that he or she has to. And then you can see over the day, over the hours, they will solve a task, but they will also get new ones. And I think that the average task number in this case is around 35. So when you start your workday, you already have 35 tasks to solve, and then you will have new ones along the day. What is interesting in this study is to look at the execution of intentions. So when a nurse has a task, he or she wants to solve it in a certain way. And we have tried to look at if it's possible the way they really want to solve their tasks. And I know there is a lot of information in this slide, but what we're interested in here is the execution of intentions. In this example, you can see a lot of dots, and all the green dots, they are execution of intentions, the way the nurses wanted to solve their tasks. So every time we have a green dot, it's a big thumbs up because everything was done as expected. When we have a yellow dot, that is when a task was solved, but not in a perfect way according to the nurse. This is where he or she wanted to solve it better or in another way. But what is most striking is these tasks. The red dots, that is when a task is not solved at all. And if you count the red dots, we have 5 executions of intentions that were not done at all in a time period of 2 hours and 30 minutes. So we have here 5 potential mistakes in 2 hours and 30 minutes. And where I come in is that these mistakes are because of disturbance of sound. And it makes me afraid to go to a hospital where the acoustic treatment is lacking and where the soundscape is really awful, because the nurses, they will do whatever it takes to do a good job. There are angels in white, trust me on this, and the doctors as well. But they simply cannot control the sound environment. They cannot control the sound sources. They cannot control the sound of the equipment. But yeah, we can actually do something to help them. If we look a bit further into the mistakes thing, because this is where the title of this session, Resilient Healthcare, comes in. We know that we can actually decrease the mistakes. I recently participated in a conference in Korea, also online. This is a brand new study saying that with more silence, objective and subjective, the less near mistakes the respondents mentioned. So we have actually learned that if we control the sound environment with acoustic ceilings and wall applications, we can actually decrease the mistakes. And as you can see here, this is a new study. I don't know if it works on your screen, but it's a brand new study this year that was published at this conference. And when we don't work with surfaces, when we don't work with the building as such, we will have some trouble with sound. And to get silence, we first need to learn about how to avoid noise. I don't know if you're as old as me, but I remember this video game from when I was a child. It was a video game where you played tennis on screen. I think it was called Pong. And then you had this white dot and that you had to capture. And that is actually how sound will act if you don't control it. Or in this animation, you will just see this sound bubble just continue on and on and on again if you don't absorb the energy of the sound waves. So this is the situation we have in healthcare if we don't control sound energy, if we don't make anything possible to absorb the sound waves. This is what we see as an optimum situation where you have some acoustic material in the ceiling. That is the biggest surface we have. And then you have some wall panels also to take care of the late reflections of the sound. This is the easiest solution I could ever show you. If you forget everything I say, just remember to have some acoustic treatment on 2 perpendicular walls, because then in maybe 80% of the cases you're home safe. And when we forget about this, we have these mistakes. And I have some examples here to show you. Some years ago, we did 3 different operation theaters in a hospital near Copenhagen, and we treated the 3 rooms differently. We had one original room with the original treatment, which was not really good, but there was some kind of treatment. The second room, we installed a new acoustic ceiling, and in the third room, we installed a ceiling and we added wall panels also into the room. And then we asked the staff questionnaires around how they felt and if they felt that they did more or less mistakes. And one of the questions was, the sound in the room makes me tired. And if you look at the columns here, the blue columns, they reflect what they answered in the room with no acoustic treatment. And the red ones are the answers from the room with the new ceiling, and the green ones are with ceiling and walls. And we can see a tendency here. The room makes me tired. You are more likely to get tired in an operation room if the acoustics are bad. So that was what they said themselves. It was an anonymous questionnaire, so they actually also were really honest. The next question was, the sound environment is stressful. And we see again the same tendency here, that the blue room, I partly agree, where we go to the red and green room, that the staff gets more and more satisfied with the sound environment. And remember that this is these are operation rooms. You don't really want a doctor or a surgeon who is stressed out by the sound in these surroundings. At least I don't want to be a patient there. And the final one, the sound causes mistakes. Yes, this is what it looks like. If you're in the blue room with no acoustic treatment, the doctors and nurses say, yes, I agree. The sound causes mistakes, or I partly agree. And as we put more and more absorption into the room, we see that they get more and more satisfied and the mistakes will decrease. So to summarize, resilient and sustainable healthcare will not happen if we don't think about the acoustic environment. That's just what we know from research. I have this summary to show. This is what we have learned from research, that if you have a good sound environment, it will lower your blood pressure, it will definitely improve your quality of sleep. And we all know that what you need when you're a patient is peace, and you need to recover in a calm environment. We have also studies showing that it reduces intake of pain medicine, and it improves communication among the staff, it lowers stress levels in general, and then there is something about improving patient safety. We heard the keynote earlier today by Dr. Jody Sherman talking about healthcare-acquired infections. We have hundreds of millions of patients affected by healthcare-acquired infections globally. And we have also know that you are more likely to get such an infection if you're in a bad acoustics environment, and you are also more likely to have hospital readmissions in departments where the sound environments are bad. So, to summarize, if we're lucky, we will end our lives listening to our loved ones saying that we did a good job. That is at least, that is my best case scenario instead of my worst case scenario. If we are lucky, we will grow old. And when we grow old, we have to go to a hospital every now and then. That is a fact. And if we're really lucky, we will push for better acoustic standards. We will push for sustainable healthcare environment, and we will push for resilient healthcare, thinking about room acoustics. And it's not rocket science. We just need to take the outdoors in regards to what happens to the sound when it spreads. So thank you for your attention.
Thank you, Mai-Britt. If you have any questions, you can write them in the chat. This is so important. Can Saint-Gobain support an initiative for benchmarking noise pollution in hospitals?
Oh, thank you for that comment. It's really complex. We are really trying to now focus on how much money can we make when we make room acoustics right, because unfortunately that's what sometimes comes first. So what we are trying right now is to work two ways into the system. We try to work with regulations, standards, local standards. So we have people locally out in the world working for this. And then on the other side, we try to work with research, we try to work with external partners that can also let the world know that noise is pollution, and it's not just because the manufacturers say so. So I'm not sure I answered your question or comment right, but we are really trying to do our best. I think that there are some other questions here. Does earphones for the patient help? Perhaps sometimes with music, but I understand that it might be helpful for the staff, but very good that you address this. Well, we have also worked together with companies that provide music as medicine. And in some cases, it is a really, really good add-on to a good sound environment. You cannot just put in a lot of music and a lot of headphones if the overall acoustic environment is bad, because then you still have the problem with sound and noise. But in many cases, it will be an advantage for the patient to actually choose the sound he or she likes. So music as medicine, yes, that does exist, but I don't know if it's a good thing to put headphones on the staff. I have not seen research on it. I'm just afraid that they will not hear the alarms or follow the conversations or pick up what they should pick up. And the last one, noise reduction indeed is very useful for everyone to avoid stress and also hearing disabilities like tinnitus. Thank you for that comment. I have 1 minute left, I guess. Okay, maybe two. Yes, we need to simply take down the sound environments, and we do that by installing acoustic ceilings and wall applications. When it comes to hearing disabilities, when we measure hospitals, when we measure the average sound pressure levels, they are really seldomly above what is okay. But the problem is when you measure average, you don't measure the peaks. And if you work in an operation room, for instance, if you're working with a saw or a drill, or it can be really noisy, and then it can affect your hearing. But what we cannot measure exactly is that what does it do to your hearing when you're constantly having a sound pressure level just below what will on paper harm your hearing, but what does it do to you if you day in, day out are exposed to higher sound pressure levels than speech and talk, but not peak noise that will damage your hearing right away. But what we're learning here is that school teachers and nurses are often the groups of people that top the list over people complaining about tinnitus. So it's a really good comment.
Thank you, Mai-Britt. We have to move on to the next speaker. But if you have any questions, we'll try to get the last questions in the end of this session. So now the next speaker is online. And it's David Brasfield from Sunnaas Rehabilitation Hospital. I leave the mic to you, and you can start sharing your screen.
Okay, this is a topic that I am passionate about. I work as an environmental manager at a rehabilitation hospital, and I like pretty much everything I do, and I'm passionate about a few things that I do, and this is one of them, so thank you for letting me share this with you. This is a CV about me. I'm not going to go through it, but you can look at it later. I have a background as an architect and an urban planner working with sustainability issues. And this is what I want you to take home from this. For everyone who is working in hospitals, I hope you consider including content about blue-green infrastructure in your sustainability agendas, content about assessment and adaptation to climate change risks, and support for healing environments, which actually does have an environmental impact, as we just heard in the last presentation from Mai-Britt. So this is two parts of the title, Love of Nature, and the other part is nature-based solutions. And the love of nature is what I'm calling biophilia. I'll explain what that is. I don't think everybody always knows that. And the other part of it is blue-green infrastructure. And of course, those things will be related to hospital design and climate change. So first about biophilia and biophilic design as a principle for healing architecture. Biophilia is a term that was coined in 1984 by an American named Edward Wilson. And basically what biophilia says is that we have an innate appreciation and need for living things and nature, actually. And the theory behind biophilia has a lot to do with natural selection and the fact that we have evolved through millions of years of evolution to be well in the natural environments that we involved in. And so biophilia is saying that if we take ourselves out of that environment where we are so well adjusted, we're going to have problems, as adaptable as we all think we are. Okay, so, and then if you turn biophilia around, there's also another term that I appreciate, which is basically biophilic deprivation, and that's called nature deficit disorder. And I actually think that's a really important term. I think it describes what most of the Western world is suffering from these days, with so much time in front of screens, so much time inside, etc. And that makes it even more important that when we are inside, that we have good healing environments, including sound environments. Okay, so we talk about healing architecture or healing architecture design for hospitals. I think actually, as an architect, I'm allowed to say that we can actually turn that around and just say that we should stop making architecture that makes us sick and unwell, which it does, basically. So hospitals, as we've heard before, they're environments with a lot of stress. And as I just mentioned, patients also come with pre-existing levels of stress, even before they know they need to be a hospital patient, due to stressful lifestyles that most of us have these days. This is just a few resources. This biophilic-cities.org, I highly recommend it. There's a lot of information if you're curious about biophilia and these things. Then there's this Therapeutic Landscapes Network. I also would recommend visiting that. There's a whole movement called forest bathing, which I think some people may have heard of. It's starting to get popular and coming on YouTube and documentaries, etc. But basically, that is also an acknowledgement of our biophilic needs, and that we are more well by having contact with nature. And everybody knows that when they go on their walk in the mountain or along the shoreline, you feel well from it, and there are very logical explanations for that. Okay, there are some tools for design of buildings and hospitals that acknowledge these things. Bream Communities talks about wellness and includes that in their assessment criteria. And they say they give credits, among other things, for green infrastructure plans. So that's acknowledging what I'm trying to say here. There's another really wonderful standard called the Well Building Standard. I would recommend that everyone checks that out. That is actually revised. There's a version 2 of that now. And Sweden is actually one of the countries in the world that is farther ahead in the uptake of the Well Building Standard. But I would highly recommend that. It can be used as a wonderful checklist for making sure that you're making healing environments at hospitals. And in the Well Standard, they also directly mention biophilia several places. Okay, and then there's also the theory and research behind healing architecture and biophilic design. And Roger Ulrich, there are many others, but he is the one who was very early out and was basically saying that contact with nature as a patient will mean that you need less medicine and that you get well quicker. Here is just an interesting comment from the health secretary in the UK, saying that hospitals are too much like production lines and that they aren't really recognizing our needs as human beings, which I very much agree with. So why should healing architecture be on the sustainability agenda? Basically, just because patients who are well, patients who are not stressed, who are sleeping well enough, patients who are less depressed than they could be because of bad environments, those patients will receive healthcare deliveries in a different way and they will get healthy quicker. And if they are getting healthy quicker, that means shortened patient stays and reduced resource consumption, which is also then reduced environmental loading, of course. Okay, so the next part of this talk is about nature-based solutions. I'm not going to read everything there, but there are a number of different things, measures that are included in what one thinks of as blue-green infrastructure or green infrastructure. And the definition is basically just using natural amenities and measures to produce some of the same ecosystem services that one can get from gray infrastructure or technical infrastructure. There are a number of co-benefits that green infrastructure delivers. I don't have time to go through all of those. You will get my presentation afterwards if you want it. I'll make it available. But biodiversity, climate change, quality of life, and actually much more. When working with green infrastructure, because there are so many co-benefits, it's important to prioritize and communicate what's important, which of those co-benefits should be optimized in any given project, for example, at a hospital. So this is just a way of structuring that kind of communication around co-benefits. And this is for a green roof, but you could use the same system, of course, for other kinds of green infrastructure. And this is my diagram here saying what I believe is important to prioritize in hospitals from green infrastructure. And those two top priorities, that's a healing environment of care and resilient and climate adapted healthcare infrastructure. But then there are a number of other co-benefits that can be also integrated into projects. And here, as you see, I've used the three pillars of sustainability. But if you start examining the 17 United Nations Sustainable Development Goals, you'll see that almost all of them are also addressed by green infrastructure. So here's I'm going to make a comparison between investing in green infrastructure versus gray infrastructure. So if you invest in gray infrastructure, you're usually, for example, in some kind of a storm water treatment system, you're putting all of your money into one outcome. If you put the same amount of money into green infrastructure, you're receiving a number of different values at the same time. And so you actually get more for your money. And in addition, green infrastructure has a lower climate loading for the amount of ecosystem services or infrastructure value that you're getting out of a project. So it's saving money, saving the climate, and giving a lot of value. Okay, now switching gears again to climate change. I'll go through this quickly. This is just a series of what has been happening in 2020 with climate change. I'm sure you have all seen many of these things on the news, but the point is that climate change is already here and we need to adapt to it. So all of these things have been on the news. Here, this isn't from this year. This is something that most people don't think of so very often with climate change, but this is the thawing of permafrost, which in the some of the Nordic countries can be an issue. Here in Norway, we are actually losing buildings due to permafrost. Here's an old hospital that is sinking and breaking up because of climate change. Okay, and then in one of the keynote presentations this morning, we also saw several examples of hospitals. We have had damages at a hospital in southern Norway where there was basically 2.6 million in damages, and climate adaptation ahead of time would have cost 1.1. So it would have been much smarter to adapt to climate change instead of react to climate change. And then just another funny one, this was in Florida. It seems that when the climate changes too much, very strange things can happen. Iguanas falling from trees because they're getting too cold. So hope nobody gets hit on the head. Okay, so why should climate change be included in the sustainability agenda? Of course, rebuilding after physical damages has its climate and environmental footprint, and also working with climate change adaptation that also gives a hospital a different awareness about how important it is to mitigate climate emissions. Okay, so now some quick examples from my hospital. I wish I could show you more examples. This is outdoor terraces. This isn't very green. We're going to get greener in our next projects at the hospital. We built a new wing recently. When we finished building it, we realized we had a view down on our wonderful panorama looking over the fjord, but looking at very ugly roofs. So we started talking about how we could improve the views and also the biophilic quality of that view. So we made a little first baby step with green roofs on a shed for waste and textiles. And then after we did that, the top management was convinced that we should do more. So that was the next step there. And now we're working on a third step with green roofs for patient recreation and being outside. There is a standard for what we call blue-green factor in Norway. You have the same system many other places in Europe, but basically this is just a way of benchmarking the blue-green quality of a building site or a building area. Okay, this is just a little nod to work done by Ecophon. I was halfway expecting them to show this project, but it's really wonderful, so I don't have slides for it. But I would recommend looking for this. It's a wonderful example here in Scandinavia of healing architecture. And then another really wonderful movement within green infrastructure is rewilding, which improves biodiversity, can affect air temperatures during heat waves, affects stormwater runoff, biophilic quality, reduces maintenance costs, and also reduces environmental loadings from maintenance. And this is a project that I would recommend visiting. There's a link down below there to this project. Anybody with a hospital site that is interested could apply for assistance from this project to examine rewilding on their hospital. More information about that and just some photos of rewilding projects at hospitals that our contact down there in Switzerland has sent. And I think that's about a landing. Thank you.
Thank you, David. Do we have any questions for David? I don't know if this one was... Yeah, I have a question for you. It's if you want to get started, I mean, landscaping is a big project, but is there a way to get started if you have green roofs, or where would you get started to get people on board to see the benefits of green landscaping?
Well, there are a number of different drivers that can be important. One is recognizing the risks of climate change and doing vulnerability assessments, risk assessments, and then seeing what kind of adaptation measures. So that will be a driver for the use of green infrastructure. Another recommendation based on personal experience, that is, start with a small demonstration that doesn't cost very much, and just show a hospital what is possible. And I can guarantee they will get very excited about it. Our top management and our board of directors are, instead of just listening, they're now demanding it. So that's a really successful way of working, I would say.
Thank you very much, David. You can ask David more questions and we'll answer them in the end of this session if we have time. I also encourage everyone to get in contact within Deal Room, and you can have a chat afterwards between the participants. And now we will continue with the next speaker, Windi Muziasari from Resistomap.
Yes, hello. Thank you, Johannes.
Hello. And you can please share the screen with us.
Yep.
I'll leave it to you.
Okay, thank you, Johannes, and the organizer for the opportunity for me to share our work at Resistomap with all of you here. I will talk about our work on the digitalization of antibiotic-resistant monitoring in hospitals. To start with, let me briefly introduce Resistomap. Resistomap is a micro-enterprise which offers antibiotic-resistant monitoring service. Resistomap is based in Helsinki, Finland, and our mission is to mitigate the spread of antibiotic resistance in the environment by providing robust tools for monitoring. So as you can see here in the figure that hospitals plays an important role in the spread of antibiotic resistance. And another point is like, why should you choose our service? Because you can get access to the state-of-the-art technology. There's no investment, no need to be an expert on antibiotic resistance, and we can deliver the result fast and comprehensively. So why is the monitoring antibiotic resistance is so important? These are news articles from BBC about antibiotic resistance. Please note that the first news here is in 2011, from 2011. It mentioned that the health experts warn about the dangers of bacteria that are resistant to antibiotics. And almost a decade later, another news showed that these resistant bacteria are already spreading in most of hospitals in Europe. So that's why antibiotic resistance is considered as a slow pandemic, well, compared to COVID-19, of course. And this is an example of a case of resistant bacteria outbreak in hospitals was in Tuscany and last year. And you can see here that there's the outbreak identification was done in week 13 to 15 in 2019. But however, when the study has been done, the outbreak actually already happened in week 44 in 2018. So this is one of the reasons why we need an early warning system to know any potential outbreak in hospital before it happened, at least to give enough time for the hospital to do the intervention to minimize the effect of the outbreak. And in this case, the outbreak of carbapenem-resistant bacteria that carried these NDM genes, it killed 31 people, like during this time, 31 people killed in 17 hospitals. So at least like if we have an early warning system in advance, we can reduce or minimal or even like stop the potential outbreak. And what can be done? So we proposed routine monitoring of antibiotic resistance in wastewater to know the level of resistance in hospital. So it's a similar like wastewater-based epidemiology. But then we need to also monitor to all antibiotics that are used in hospital. In case in Helsinki, the hospital used beta-lactam, quinolone, and vancomycin. So our service is a complete service starting from sample collection, antibiotic resistant analysis, and delivery of the report within 3 to 7 business days. To show the importance of routine antibiotic resistant monitoring, we conduct a project for routine monitoring of antibiotic resistance in wastewater from hospitals and municipal wastewater treatment plant, together with the infectious disease control unit at Helsinki Central Hospitals, or HUS, and also from the HSY from City of Helsinki. The project is supported by Business Finland and Takara Bio. So we collect the wastewater samples from 2 HUS hospitals and a municipal wastewater treatment plant with the capacity of 800,000 population in Helsinki. All of these hospital wastewater are also treated in this wastewater treatment plant. And that's one of the reasons we collect the samples from all these locations. The first hospital is the Triangle Hospital, and it's known that the use of antibiotics is quite high. And then the second hospital is a New Children's Hospital, and the use of antibiotics is pretty low. And we monitor for 9 weeks, from week 25 to week 33. And we usually collect the sample between 8 to 9 a.m. in the morning when the first flush from the wastewater. So we directly concentrate 100 milliliter of the wastewater on the PS membrane here. Of course, we need to also protect the safety because this quite even there is no, the hospital not treating any COVID-19 patient, but it's still like just to prevent any kind of potential disease. And to maintain the quality of DNA extraction, we perform DNA extraction using the QIAcube, in this case, the machine, like and Power Water DNA kit, just to have a similar quality of the DNA extraction. And we analyze 1 microgram of DNA samples using the SmartChip qPCR method to detect and quantify hundreds of resistant genes comprehensively. So for some of you who are not familiar with the SmartChip qPCR system, it actually has a similar technique with qPCR test for the COVID-19. So we just detect the genes or the genetic material from bacteria. However, with the SmartChip system, allows us to perform up to 5,184 reactions at once, or 54 more compared to the standard qPCR. And the process only takes about 6 hours. So we use primer set or assays that have been validated and published previously to analyze also antibiotic resistant genes in wastewater. And then also the primer set of 2.0, that is the updated version of this primer set. And we also did in silico test to update the primer set with the current database from NCBI and ResFinder, just to make sure that the primer set is targeting antibiotic resistant genes. The SmartChip qPCR has flexible configurations. We first pre-screen the presence of the genes with 384, and then we found around 180 to 200 genes. And therefore, we choose this configuration, 216 genes for 8 samples, so that we can save kind of half of the expenses. But of course, if we only concern a few genes, let's say like only certain genes that are already high abundance in the hospital, so we can have study few genes, but we can analyze 128 samples at once. So this is why that the SmartChip is quite comprehensive and high throughput. And then to make the analysis or like the process fast, we also develop our own in-house analysis in the cloud system, so that we can deliver the data analysis as fast as in one click. And this is the result. We found that the gene profiles of the antibiotic resistant in Hospital 1 and Hospital 2 were distinct from each other. But the number of detected genes over the time seems like quite similar in both hospitals. But let's take a closer look to the abundance of detected genes, which is shown in this heat map in Hospital 1. So red color means the gene abundance is high, and blue means the genes abundance low, and white means the genes were below the detection limit. The heat map shows the resistant genes found in hospital wastewater, which confer resistance to antibiotics that are used in the hospitals: beta-lactam, vancomycin, and quinolone. As you can see here, that more beta-lactam resistant genes found, and in the week 27, 28, 29, it seems like there are more genes, resistant genes also in the vancomycin, the genes quite increased. And then if we compare now to the children's hospital, now you can see why that the resistant genes profile between these two hospitals are different. And as I think this also may be the impact of less use of antibiotic in the new children's hospital. So the heat map of resistant genes from HUS 2 shows the abundance of detected genes was lower compared to HUS 1 or in the first hospital. But this information, I believe that is pretty comprehensive. I think it's good if you are a researcher, right? Like, because more data is like more things to be analyzed, but it is not optimal if you want to know quickly what's the meaning of the result of this monitoring, especially for the hospital management when you have very busy time. So therefore, like, we are now building a digital platform to show an overview of antibiotic resistant monitoring. Like in this case, this is a mock-up example to show the result from HUS 1. So this is still what is called like still mock-up. So we are still now trying to figure out what is the most important information for the hospital from all of this comprehensive data. But at least we can combine the information of antibiotic use. In this case, antibiotic use DDD per 1,000 patient days monthly, because I knew that at least in Nordic country, most of the hospital has the data of the antibiotic use. And then we can see that the level of the resistance are also quite similar with when the use of antibiotic increase, the level of resistance also increasing. And yeah, and then we have one alert here, so we can add something like alert. And here, as I mentioned, and as we can see here, that there's an increase of antibiotic use in July. So that's the level of resistance. We also can show a more detailed report of certain group of antibiotics. Let's example, but beta-lactam, because it's quite the most type of antibiotics used in the hospital. And then we can see now here there is a trend, the trends of carbapenem-resistant genes over the time. So it's over the time. And as there are different classes of carbapenem-resistant genes. And then we can again have the same alert here. The first alert that Beldam from the class 1 carbapenem-resistant genes, and Brasfield from the carbapenem-resistant genes class B is pretty much quite high over the time. So the red dashed line here is a kind of the average of resistant genes in the nature and in the wastewater. So that's why when the level of resistance over this dashed line, that it's considered quite high abundance. Or it means like 1 in 100 or 1 in 1,000 bacteria carry these genes. And yeah, so also here, connecting to the story of BLA-NDM outbreak in Tuscany, so we also can see here that BLA-NDM detected in every sample. So we can put here an alert that MDM is found in all sample, but you can see here that the abundance is pretty low, so there is no more alert on this presence of the BLA-NDM. But then again, if this BLA-NDM genes found quite high, then maybe there's a potential, there's some going on in this world that the infectious disease control can check their data or can start, like intervention, like collecting more sample from the patients to find out what is potential source, and then make sure that those patients who carry these genes should be quarantined or isolated. And then, of course, then we also can show the information not only based on the genes over the time, but also weekly based on all the resistance to beta-lactam. As you can see here that quite clearly in July, or at least in the week 27, 28, 20, and 29, the level of resistance is pretty increasing. So maybe this is also associated with the use of beta-lactam. And this is kind of warning if the use of antibiotics are increasing and if the level continue increased. And of course, again, the heat map. So this one, if you want to more detail what happened these genes compared to the other genes. Basically this, and of course, like some of you may not familiar what is BLA-TAM, what is BLA-SHV, because like I don't think you will memorize all this name of these genes, 100 of these genes. So we have also this knowledge base which connected to the ResFinder database. I think if you work with antibiotic resistant, you know that ResFinder quite nice. Actually, I understood that is also here in Denmark. And yeah, sorry. Now continue from this hospital, wastewater hospital. As we all know, then most of the Nordic countries, wastewater from the hospital are treated in municipal wastewater treatment plant. So indeed, we found quite high association between the number of detected genes in the 2 hospital and the influence samples. And this quite high, especially from the hospital one when the use of antibiotic quite high. But of course, this association is not causation. It's just to show also that the level of resistance is similar between the hospital and in the wastewater treatment plant. And then if we focused on the 5 most abundant beta-lactam resistant genes found in the hospital, CFXA, BLAGES, BLAFIM, BLATAM, and BLAKPC, and again the NMDN because of our story before, you can see here that, for example, BLAGES quite high abundance in the 2 hospital. We also can see that in the wastewater treatment, the genes are slightly high abundant. But then for the BLAFIM, which has high abundance also in the 2 hospital, but not necessarily high in the wastewater treatment plant. So for this, in this case, BLAFIM, it seems like only, let's say, prevalent in the hospital or only carried by bacteria there in the wastewater in the hospital. but not in the environment. However, this is alert here that for the blackies, well, the resistance of quite high and also in the community. And this is, I would say, like, is not good situation when all of these resistance are high abundant in hospital, also in the community, because as I show in the first figures, the spread of resistance is connecting to each other, especially from the hospital to the wastewater treatment and then to our water environment. And of course, we don't want these resistant genes are spread and high abundance in our environment. But then again, if they are low abundance, it's slightly low, that you can see quite low, and also for blood NDM, and it's good that the resistant quite low abundance also in both hospital and the wastewater treatment plant. So at least in this situation, we can assure that the outbreak of blood NDM is less likely for now, at least here in Helsinki. And to conclude, routine monitoring system can show the dynamics of antibiotic resistance for predicting resistant gene patterns in hospital. And the digital platform of this antibiotic resistant monitoring can be used in an early warning system to detect impending outbreaks of resistant bacteria. That's what we hope. So that's all, I think. I'm very happy to answer if there's any questions, and thank you.
Thank you, Windi. Do we have any questions in the chat? I can start with one. I'm just thinking about, can this be used in like a big data, if many hospitals are going together to create a database and to monitor the spread of different diseases?
That's what I'm hoping for. Actually, that's why we are building the database in Resistomap. And that's why if you see that in the very beginning, I make sure that all the analysis done in the similar way, like to have the data integrity on every data that we analyze. And yeah, we are building this database also for the global monitoring, not only from the hospitals, between hospitals, but also in the the surrounding environment, like including the wastewater treatment. As you may know, many city sewage system are connecting. So whatever happened in the hospital may also impact to the community. And also, of course, from the animal farm, because most of the antibiotics are used actually at the animal farms. And this might affect the, the resistance to the environment. So this database is like, it will be like we hope to build in the global monitoring, for the global monitoring, including from the hospital. Yeah, that will be great. We are going to that direction, and I hope that now coming, I believe that most of the people here coming from the healthcare, that will be great that we can combine all of this information together so that we can prevent outbreak in one location, or at least in one hospital to the other hospital. But I understood there is an issue with the open data access. As long as we can do anonymous, maybe that the data still can be accessed publicly. I think that's, at least in my opinion.
Thank you, Windi. That would be great to see some kind of like global warning system for different diseases. Yeah, thank you, Windi. We'll go to the next speaker, Amina Pereno from Politecnico di Torino.
Here I am.
Yeah, welcome. You're welcome to share your screen.
Yeah. So, yeah, thank you, and good afternoon. I'm Amina Pereno from Politecnico di Torino, and since 2015, I've been working with the Nordic Center for Sustainable Healthcare, collaborating with them on many different topics on sustainable healthcare. And today I have the chance to present and discuss with you. I hope we still have some minutes after my presentation to discuss about future and resilience. So this is challenging, but I hope to be short and show you some results emerging from the workshop that Nordic Center has led in 2018 and 2019. First of all, this is the starting point and the main statement. I think we all agree, as will not be here now. So the future of our health system must be sustainable. This is a great starting point, but what does it mean? It is actually difficult to define sustainable healthcare. So how can we define its future? I think all of you have some idea on possible future evolution of sustainable healthcare, but would be foolish to think there is only one possible future. That's why what future, or better, which futures, is the question we should pose. This visualization is called future cone, and it is meant to visualize how, starting from the present, we can try to forecast and to understand what is possible in the future, of course, and within the possible, also the plausible. But going further, we can also, based on foresight techniques, understand what is the probable future to reach. But the real challenge, and that's why foresight techniques are useful, is to define what is preferable. So basically, which is the best future we would like to achieve for a sustainable healthcare. This was basically the starting point of the World's More Sustainable Healthcare 2030 project that was led by the Nordic Centers, and I'm collaborating it with them in the final part. So starting from the analysis of the present situation, the Nordic Center involved many stakeholders. Maybe someone of you took part in these workshops to define possible future horizons on sustainable healthcare, as well as the strategies to achieve them. I will briefly show the path followed, because I think is important, but I will be short on this. So the project was based on 5 workshops that involved around 1,065 stakeholders around Sweden. Let me remind that also many of companies, organizations are cross-national organizations. So we have a good and wide representation of different stakeholders. Of course, health providers, so all hospitals and health organizations providing health services, health companies that are supplying products and solutions to health organizations, but also a good representation of regional and national authorities and of university, R&D organization, as well as clusters of companies and in other bodies, as well as the NGOs and healthcare networks that first starting working in sustainable healthcare, and also some professional consortia that include interbranch organization and in a minor part also patient organization. This was important to because these keywords are those emerging from the workshops are actually representing of the sector. So stakeholders were engaging in the workshop and provide this set of ideas and keywords about the future roles of health industries and providers and patients, but also the collaborative methods and processes that can connect them. So we can say a framework of the future of sustainable healthcare. Well, my work and the challenge that was posed to me was to move from ideas, or maybe not move, but organize ideas into consistent scenarios. If you will have time to look at that keywords, you can see some of them are maybe in conflict or alternatives. So we have to create some consistent scenarios to address. That's why I use this foresight technique called Three Horizon View to summarize the scenarios that were emerging. The first one called business as usual. This is a linear evolution of the present situation. Then we have a mid-term scenario that is called disruptive innovation. So we have at this point some innovation that is able to change the present situation, and that led us to the emerging future that we can say is the desirable futures we would like to achieve. Going a bit more into depth of this scenario, the first one, we call it fragmented green healthcare. Please consider that this is not a bad scenario. It's just the future projection of what we consider is the present situation. So the focus on resource efficiency and waste management technologies will increase and lead to better and better solution. Also, the implementation of national green public procurement strategies is a very positive point that can help companies and organizations to evolve, increase their sustainability. But it's important to underline that fragmentation is still a problem from this scenario perspective. We have isolated governance actions, and basically the main issue is that is still missing a supporting environment for companies and organizations that want to actually be radically different and radically sustainable. So the second scenario that is called usually disrupting innovation, well, in the sustainable healthcare perspective, we call it transitional dynamic healthcare. From this perspective, distributed healthcare schemes will spread. So you can think to home care, but also neighborhood care services that in the present are growing in the interest of different countries and also health systems, but this will increase. And beside green public procurement, we can also find innovation procurement strategies that are considered as very important and effective in leading innovation and offering also startups and other small companies the possibility to invest and provide radically different innovation. Cross-sectoral forums and events like today's one, but also like the Nordic Center is doing and has been doing in this year, will be more and more important. This situation can lead to cross-border governance actions. This is important to open the market to new solutions. Of course, Nordic countries are excellence in sustainable healthcare, but the opportunity to open this market and at a European and global level is, of course, essential for the sector. And finally, the third scenario that we call collaborative and regenerative healthcare is, as I said before, the desirable scenario, the desirable future of sustainable healthcare. You can find many of the points that were present in the previous one, such as distributed health system, but also dynamic supply chain. But what is changing is the organization of the stakeholder and of these networks. I try to summarize this scenario using this visualization. You can see, you can find all the stakeholders that are in the present, the main one, but also all the networks and the value constellation, we can say, that are composing the supply or the provider, health provider systems, but they are systematically organized in a different way. So on the one hand, we have dynamic supply chain networks that will be able to address some problems that we are facing today. I think also the presentation by Professor Jody Sherman this morning confirmed how the pandemic and other climate-related events have a huge impact on supply chain. Well, a resilience of these supply chain networks will be essential to address future challenges. On the other hand, distributed health systems are also important and will allow to enhance the role of patients. We are talking about patient-centered healthcare. Well, that of course can be the future also from a sustainable healthcare perspective. And then also the end of waste and all the end of life of product and services will gain attention and importance in the system. So focusing on circular solution for waste to resource and for waste valorization. Cross-sectoral forums are not just organizing some events or opportunity for networking, but should be an actual point in social sciences. They call it publics. That means some public places to discuss and build opportunities for innovation, research, and also for market. Well, but the following question is how to practically move towards this emerging future. We define, starting from what emerged in the workshop, some possible strategies, dividing them in three main categories. The first one is innovation. So we think was very important the development of models and tools that can help companies, especially, and businesses to evaluate the sustainability of solutions. LCA is, of course, one of these tools, but is not enough and is not easy to apply, especially for disruptive innovation and small companies. Another strategies that could be important is to support test beds and we can say accelerators also from a digital perspective to allow support startup and companies provide a radically different innovation. And also, of course, as I said before, forums, arenas, and other places that can encourage and promote a joint R&D project. The second category is information. So one of the main goals is to increase the collective knowledge about sustainable healthcare, starting from the university. So introducing sustainable healthcare topics into university curricula that will train the future health professionals. But also, of course, promoting information among decision makers with campaigns targeted at policymakers and people that are in charge for regulations at local, but also and especially at international level. And last, the collaboration strategies about that can increase national collaboration. Of course, the local dimension is the starting point. Bottom-up collaboration is fundamental. This means start developing a national agenda on sustainable healthcare and also promoting vision building events or activities that can help in a mid-term future to establish maybe a Green Deal for sustainable healthcare or other private and public initiatives that can actually support hospitals in adopting sustainable strategies and companies in providing sustainable solutions. To conclude, it is important to underline how the local level is at the core, at the base of the strategies, but we would move to an international and global perspective. Nordic countries, as I said before, are leading sustainable healthcare and are offering many excellent innovations in this field. But we need to look at the shared vision of sustainable healthcare and a global perspective. Again, I think many contributions this morning highlighted this need to be to think globally, even if starting from the local and national level. If you want more information and have a look at this research, we have published it in a journal, and this is the link for free access. You have still 1 week to read it and download it. I will share it in the chat. And then this is the question and answer slide, but I pose a question to you. So I briefly show you some of the results we achieve and some of the main strategies that could be implemented. So where do you think should we start from? Information, collaboration, or innovation? I hope we can have still some time to discuss. I don't have, just 1 minute, but let me see if there are some questions. And thank you.
Yeah, thank you, Amina. We have one question here. We have still some seconds left. What emerging trends do you see in the future for sustainable healthcare?
Well, trend is a wide term, let me say. So there are many trends. As I said in some of the previous slide, I think, of course, patient-centered care will be important, and especially this distribution of healthcare that, on the one hand, means to improve acute illness treatment in hospitals, and on the other hand, to be closer to patients. I think is very important. But at the same time, dynamic supply chain are the futures, not only as concern healthcare. That is a trend that will affect many different sectors, because also climate change are leading to many unforeseeable events. So I think, supply chain, that will be the main two trends in sustainable healthcare in the future. That's why resilient can be a good companion for sustainability.
Yeah, thank you, Amina. Unfortunately, we are running out of time, so I hope you can maybe continue. Get some comments from David here in the chat. Maybe you can continue there, and you can also continue discussion and asking the speakers in the lobby of Deal Room. And I would like to thank all the speakers and the audience for your participation in this session. And with that, I would like to we have to move on to the next session, and I hope you will follow us in this room. You have to log out and into the next one, of course. Okay, thank you very much.